Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hey everyone, welcome back to Cardiovascular Matters. We're celebrating Men's Health Month. Last week we talked about cholesterol-lowering medications that were kind of the front line of defense. They've been around for a long time. They're also generically available. Today we're going to take a step, go a little further. Dr. Walker alluded to some of these medications last week, but it's a class of drug. I hope I get this right. It's a PCSK9, and I believe that's an injectable. That would be, I guess, a bigger step in tackling these big issues. Dr. Walker?
Sure. So obviously, as we mentioned previously, high levels of LDL cholesterol are a big problem. And as I've mentioned, the way that we lower cholesterol is to either make less of it or to make sure that our body metabolizes the LDL cholesterol. Now, the way that LDL cholesterol is metabolized is on the surface of our liver. We have things that are called LDL receptors, or low-density lipoprotein receptors. These bind the circulating LDL molecules. They internalize the LDL molecule into the liver, where they metabolize the LDL, getting rid of it, and then they should be able to recirculate and go to the outside of the liver to continue the process of, if you would, chewing up LDL cholesterol. Mm-hmm. Now, our body can make a protein which was discovered in the past by Amgen. And this is a protein that has been given a big name. It is called protein convertase subtilisin kexin 9. That's why we don't call it that. We call it PCSK9.
9, yeah.
And this PCSK9 protein blocks our ability to metabolize LDL cholesterol. Now, the way that it does this, Terry, is this protein binds to the LDL receptor. It has a high affinity for that LDL receptor, and it was found in people who genetically had very high levels of LDL cholesterol. Many of them had high levels of this PCSK9 protein. So early on, the thoughts were, well, maybe if we could do something to neutralize that PCSK9 or protein convertase subtilisin kexin 9 protein, that it may allow these LDL receptors to do the job that God intended them to do, and that is to continue chewing up LDL cholesterol. And so the first attempt at dealing with this was to create what we call monoclonal antibodies. Mm-hmm. These are antibodies that then can go out and attack the PCSK9 protein, not the LDL receptor. They bind first to this PCSK9 protein, and that stops it from being able to bind to the LDL receptor, because once that protein binds to the LDL receptor, otherwise, when the LDL receptor picks up the LDL molecule, it goes into the liver, but it's destroyed at that point. It cannot recirculate to keep chewing up LDL cholesterol. Now, if we use the antibody, which was the first form of PCSK9 medication, and there were two companies that make this. One of the drugs is called Repatha. The other drug is called Praluent. They're made by Amgen and Regeneron, respectively. These are very, very effective at lowering our LDL cholesterol because these antibodies go out when they bind to the proprotein convertase subtilisin kexin-9 protein. They neutralize its ability to bind the LDL receptor, allowing our LDL molecules, our LDL receptors, to chew up and get rid of this LDL cholesterol. Now, those medicines have to be given either once every 2 weeks by subcutaneous injection, they're given by injection, or once a month by subcutaneous injection. So we can use those, and those will control LDL cholesterol very effectively. These are an incredibly powerful set of medicines which control LDL cholesterol really far greater than anything that we've had historically. These really bring down LDL cholesterol pretty profoundly, and they have been shown to certainly lower cholesterol. And in one of the studies with the Repatha product, the part of the trial called GLAGAV actually showed regression of atherosclerosis. And in the Ebbinghaus part of that trial, showed that they did not adversely affect brain function, that we did not see any negative outcomes as we really lowered LDL cholesterol. And these drugs frequently allow LDL cholesterol to be reduced below 25, very, very low levels. It allows us to really lower cholesterol. Now, you may ask, why is this important? Well, following coronary intervention, be it surgery or stents or problems, treatments such as those, often we cannot achieve the guideline-directed therapies of LDL cholesterol. Certainly, always should be less than 70, but some of the new guidelines say less than 45. We typically could not do that with just other medicines. These medicines have allowed us to do this. Now, more recently, another medication that addresses the PCSK9 protein has been approved by the FDA, and it is called inclisiran. And this medicine actually stops the production of the protein. It is a messenger RNA, not an antibody. And this is given in a different way. It is also given as a shot, but instead of a shot that has to be given at least every month or more commonly every 2 weeks, this is given as first a loading dose at 3 months, a second dose. But then after that, it is administered only once every 6 months. And it controls the production of LDL cholesterol, or it controls our ability to control LDL cholesterol for a 6-month period. Now, we do not have head-to-head trials of the antibodies versus this messenger RNA drug to determine which is more powerful. But suffice it to say that both the messenger RNA iteration and the antibodies seem to control LDL cholesterol levels very, very well. And certainly I cannot state one better than the other yet. Certainly there may be some advantage to not having to take a medicine more frequently, or there may be a certain advantages to not having to take a medicine or to taking a medicine more frequently. But we're going to find that out over time. But these medicines have proven to be very effective, particularly helpful in patients who simply can't take statins because of muscle aches. But even on top of statins, have shown to reduce cholesterol dramatically, achieving the levels that we hope to have to prevent disease recurrence.
So I'm just curious, let's say a patient has a really high cholesterol level. You've got them on statins, they're tolerating it, but you can't get them even close to the target of 70. Is this another tool? Can you use these in combination?
Yes. In fact, these are usually used in combination. These are not generic. These are therefore more expensive.
Right.
Okay, that's just simply put. But these are incredibly powerful at reducing future events and in really lowering cholesterol. And so I think that these have really helped to revolutionize how we can control lipids. And so they're one more tool in our toolbox. Again, some of the new diabetic medicines also have profound effect on lipids. But when we have a patient with advanced atherosclerotic disease and they're on statins and our LDL cholesterol is not at target, if we don't get it to target, we know that that person is more likely to have subsequent events. Mm-hmm. This medicine is a powerful adjunct. This medicine really helps us to limit those risks of events. And it has the FDA approval for that. And certainly, that's where, I think these are medicines that I often go to very early on, particularly in my patients who have most advanced forms of atherosclerosis. Mm-hmm. Because in that case, even though there is an expense to these medicines, it is a lot lower than the expense of repeated hospitalizations, recurrent heart attacks, strokes, etc. And so these are very, very powerful medicines that can really lower cholesterol. And in the case of the antibodies that have been shown to limit future cardiovascular events. Again, the messenger RNA has been shown to limit, to drastically lower cholesterol. We don't yet have all the outcomes data, but that is being evaluated. And it's my suspicion that those will probably also limit events, because lowering cholesterol typically does that, but we have to wait for those studies to be able to say that for sure.
Well, this was, it's encouraging that patients have options, and they have, you have a toolbox to include these injectable medications to really knock down high cholesterol and get those patients back on a healthy track. Once again, we thank you for your incredible expertise and knowledge of these drugs and how you use them in your practice. And next week, we'll pick up with more issues concerning men's health. Thank you very much for helping us out, Dr. Walker.
Thank you, Terry. It's been my pleasure.
Thank you.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.